Hi, my name's Kirk Morris. I'm a full-time clinical haematologist at the Royal Brisbane and Women's Hospital. The title of my presentation today is Bridging the Geographic Divide for Myeloid Leukemia, a statewide system accessible to everyone. More specifically, I'm here to talk about the Queensland Myeloid Genomics Project, program we've now been running for more than 12 months, and I'm hoping to highlight the benefits of collecting structured data and providing a real-world example of recording consumable genomics information. Each year in Australia, around 900 children and adults are diagnosed with myeloid leukemias, and it remains amongst the more challenging diseases that we as haematologists treat. Despite the use of very high-intensity chemotherapy, relapse is common. Our most powerful therapeutic weapon has traditionally been allogeneic stem cell transplant, but just to recognise it's also a very feared therapy associated with significant immediate and long-term risk. In September 2019, the Queensland Myeloid Genomic Program formally commenced with the intent of providing haematologists from across the state access to modern genomics testing for myeloid malignancies, with experts interpreting and supporting clinicians via a teleconferenced MDT. We needed a simple and accessible system to collect clinical and disease data, and this is where COOL has come in. Modern genomics is providing us with significant higher levels of sophistication with respect to establishing prognosis to guide our decision-making processes. Historically, prognostication of myeloid malignancies has been based on vague or subjective patient characteristics and hematologic parameters. These parameters are obviously simple and somewhat established, but you might also say they're unsophisticated. For some time then, chromosome analysis or karyotyping has provided us the ability to stratify myeloid leukemia patients into favourable, unfavourable and intermediate risk groups. But with karyotyping alone, around 50% of patients would land in this intermediate or grey zone category. And it's always been clear that even within this group, different patients would behave differently. This is where subsequently the use of directed PCR has provided the ability to identify a small number of mutations with prognostic significance, and some even that are therapeutic targets, but increasingly broader molecular panels and next generation sequencing now providing exponentially increasing data about an individual's disease. Whilst this might appear to bring a high degree of sophistication, there's a huge amount of complexity and uncertainty about how to use this data in a real-world clinical setting. So this leads to the QMGP. It's a fortnightly teleconferenced MDT attended by members from all large haematology centres across the state of Queensland, which includes the Royal Brisbane Women's Hospital, Princess Alexandra Hospital, Gold Coast University Hospital and Townsville General Hospital, plus also from the Queensland Children's Hospital. It's led by expert clinicians, pathologists and molecular scientists. The project offers testing with a 37 gene panel in parallel with existing targeted molecular testing that's provided through Pathology Queensland, and then clinical annotation and discussion at a multidisciplinary meeting aiming to build local expertise and provide practical clinical advice to referring clinicians. The project uses a secure web-based ecosystem developed by the Cancer Alliance Queensland that is accessible anywhere. It provides an end-to-end solution for clinical MDTs, from referral through to the reporting and data analysis at the other end. There are quite a few benefits to it. It's quite flexible and customizable, fully accessible via the web interface, but equally secure, and you have full control over user access. Provides efficiency in that it is a single and centralized way to refer, discuss, annotate and produce reports and extracts. It encourages collaboration by being a patient-centric system. Data is shared across services instead of being siloed in ad hoc databases. And it leads to research opportunities by being a statewide system that houses a lot of uniform codified clinical data in a significantly clinically meaningful database. As I've already indicated, treating myeloid malignancies is hard. Even just storing the data, let alone interpreting it, is complex. COOL provides us this single source to view public and private pathology, chemotherapy, radiation, diagnosis and death data, and this is quite a unique system in that regard. Here are some of the screenshots of COOL in action. To start with the referral pages, I hope to show the intuitive interface, the clinician-led development, and that it is customizable. Just recording the diagnostic data, it's expected that the treating or referring physician will provide accurate diagnostic data. And I'll just comment that I think a whole lot of clinical data collection systems use disease classifications that clinicians on the ground don't actually use, such as ICD and SNOMED. And so in the design of this system, we specifically incorporated WHO morphology to align with the terminology that we as practicing haematologists use. And we've intentionally tried to keep it simple, so as, let's say, not to overwhelm the clinician at that point of referral. We custom built calculators for commonly used and clinically relevant prognostic scores, and I personally see this as providing some incentive for entering the data accurately. It provides some instantly usable clinical information. We have structured collection of legacy cytogenetic data, which is aligned to well-established prognostication systems, and for us that's the European Leukemia Net, and similarly for the legacy molecular panel performed by Pathology Queensland. Capturing the more complex molecular sequencing panel, this is entered by the hematopathologist performing the curation. We've tried to again design it to balance complexity of collecting all aspects of the genomic information versus trying to keep clinically relevant and simple information for the referring clinician. The recommendation panel similarly intentionally kept simple. Key discussion points and the collective perspective of the group can be summarised here, from which a uniform report is generated at the end of discussion. Amongst the value of the MDT is that each site across the state has clinicians with different strengths. That includes clinical expertise, transplant or a non-transplant focus, and some particular clinicians and scientists with well-developed molecular expertise. The existence of this statewide system housing a whole lot of uniform codified clinical data means that we have a powerful database, and this leads on to research opportunities. This is just the very first look that we have had at whether our project is helping us out at all, and very broadly you can see that we believe that the project has provided 70% of cases some clinically relevant findings. In a lot of cases it has supported our plans to allograft, and just to recognise that's not always an easy decision, but in other circumstances may alter our diagnosis, change donor selection that may have to do with the presence of germline mutations which have been identified in certain circumstances, and has in other circumstances changed whether we're going to transplant the patient or not. So in conclusion, having access to an ecosystem that encourages efficiency, collaboration and research has been a key indicator of success for us.